Now let's talk about nitrates, that why you people cannot give nitrates in right ventricular infarction. Dear doctors, as part of our lectures on ischemic heart disease, today we are going to talk about myocardial infarction, and we are starting from pathogenesis. So what exactly happens in myocardial infarction is that there is a rupture of atherosclerotic plaque. Rupture of atherosclerotic plaque. This is the pathogenesis. There is 100% occlusion of coronary vessel due to ruptured atherosclerotic plaque. This is the pathogenesis that drives the clinical features and complications of myocardial infarction. Now you people might ask that in unstable angina, we also had the same pathogenesis. Ruptured atherosclerotic plaque was also seen there. Distal portion of coronary vessels were blocked. But what differentiates myocardial infarction from unstable angina is that the duration of symptoms actually lasts more than 20 minutes, right? So this duration will actually tell you this duration. In myocardial infarction, the typical symptoms will last more than 20 minutes. But in unstable angina, symptoms will not last 20 minutes, right? This is one way to differentiate unstable angina from myocardial infarction. But if you people can recall, in unstable angina, troponin levels were absolutely normal. But in myocardial infarction, later on we will see that troponins will be elevated. The cause of elevated troponin is due to infarction. You people can't see any necrosis in unstable angina. But in myocardial infarction, there will be necrosis of myocardium due to ruptured atherosclerotic plaque. Basically, there is 100% of occlusion that actually drives the necrotic myocardium and hence contributes to most of it. Let me tell you people that we won't be covering complications of MI today. This is a separate lecture. Now let's talk about rare causes. Sometimes, apart from atherosclerotic plaque that we have just discussed over here, vasospasm can contribute to this. Vasospasm of coronary vessels. Vasospasm can be due to cocaine abuse, or it can be due to prinzmetal angina that we discussed in our prior lecture. Another rare cause that can cause myocardial infarction can be vasculitis. Vasculitis, such as Kawasaki. Kawasaki disease can actually cause MI in children. This is one of the most rarest causes of MI in children. Now we will talk about clinical features of myocardial infarction. A patient suffering from myocardial infarction will present with severe chest pain, sometimes described as crushing chest pain, and patient will be actually sweating, means diaporosis will be seen there, shortness of breath will be seen there. Remember, this chest pain might be radiating to the arms or jaw. Now you people can ask that MI involves which ventricle? Let me tell you people that MI can involve left ventricle as well as right ventricle, right? And you people have to be very careful dealing with MI patients who present to the emergency department with right ventricular infarction. You people have to really rule out this right ventricular infarction because we want to avoid nitrates. So we have to avoid nitrates in right ventricular infarction, and we have to give lots and lots of fluid in right ventricular infarction. Contrastly, if you have got infarction of left ventricle, you people have to avoid fluid overload because patient might be having left ventricular failure already. So patient will be having pulmonary edema. We have to avoid fluid overload. So these are very contrasting types of MI. Left ventricular infarction, you people have to avoid fluid overload. Right ventricular infarction, you people have to avoid nitrates. Instead, you people have to give patient proper amount of fluids. MI can involve different arteries such as left anterior descending artery, right coronary artery, and left circumflex artery. Before talking about these specific arteries involved in MI, you people have to be familiar with parts of the heart fused by these specific described arteries. For example, left anterior descending artery is gonna feed your anterior wall of left ventricle as well as anterior septum. It means if a patient has got MI and this MI is involving left anterior descending artery, means this artery is occluded. So the infarcted portion seen in the heart will be anterior wall of the left ventricle as well as anterior septum. This is what we are going to see in case of left anterior descending artery MI. Remember that on ECG, you people will be having ischemic changes in V1 to V4. And we should be talking about the mechanism behind V1 to V4 being involved in left anterior descending artery. But for today's lecture purposes, you people have to just note that in case of left anterior descending artery involvement, the ECG leads that will show ischemic changes will be lead V1 to V4. In another example, if right coronary artery is involved by the MI, what exact portions of the heart will be involved? Let's talk about this. Right coronary artery feeds posterior wall of the left ventricle as well as posterior septum. And last but not the least, very important, right ventricle. Remember this at the back of your mind that right ventricle is supplied by right coronary artery. And one very high yield factoid is that the nodal system means the SA node and the AV node is also supplied mostly by right coronary artery. Out of all these involved portion, right ventricle and the nodal system is very high yield. Let me remind you people that in case of right coronary artery, the ischemic changes on ECG will be seen in lead 2, lead 3 and AVF. Coming back to these high yield portions involved in right coronary artery MI. If patient's MI is actually involving the right coronary artery over here, right ventricle can be infarcted. Now let's see the impact of right ventricular infarction. We have already talked about this factoid that the infarction can involve left ventricle or right ventricle. And you people have just learned that right ventricular infarction is seen due to right coronary artery. More specifically, it will be PDA, posterior descending artery, which itself is a branch of right coronary artery, right? So if you people see ischemic changes in lead 2, lead 3 and AVF, this is an alarming situation. Why it's an alarming situation? You people should avoid nitrates in such patients. Also, don't forget to give this patient fluids, adequate amount of fluids. Fluids are very important, right? Gonna feed nodal system. For example, a patient is having right coronary artery MI, so nodal system can be affected. How will patient present with? Patient will present with bradycardia, because over here, if right coronary artery is occluded, this right coronary artery occlusion will lead to failed nodal system. So what will happen? Patient will be having bradycardia. That's why we always avoid. So there is a second drug that should be avoided in case of right coronary artery. That drug will be beta blockers. Now let's talk about left circumflex artery. Left circumflex artery is going to feed your lateral wall of left ventricle. So it means the left ventricular lateral wall is affected in case of left circumflex artery. Okay, let's talk about the lab test that we can do for patients suffering with MI. Remember that troponin are mostly used in acute settings. We have to talk about the high yield points related with troponin and as well as CKMB. Remember that for acute changes, to detect acute changes, we have to use troponin over here, right? For example, a patient is presenting to the emergency department and you people want to detect necrotic changes seen in myocardial infarction. You people have to order troponin, right? But if you people want to detect recurrent changes, you people have to order CKMB. Let's break this down, that why we use troponin in acute setup and CKMB for recurrent MIs. Remember that after 3 to 4 hours, troponin level rise in a patient with MI, and it actually normalizes after 7 to 10 days, right? That's why these are the earliest biomarkers that are elevated in case of myocardial infarction. Since they are the earliest biomarkers elevated in case of MI, we use them in acute setup. Now CKMB, after being elevated, it actually normalizes after 24 to 48 hours. Now let's see the significance of this specific point. For example, a patient presents to emergency department and you people detected inferior MI, and this patient underwent PCI. Patient was stabilized, but after 24 hours of stabilization due to PCI, this patient got another MI, right? Now to detect another new MI or recurrent MI, you people have to order CKMB because it's gonna normalize after 24 to 48 hours. If you people order troponins are always elevated, right? It is reported to be elevated as long as 7 to 10 days after MI. So you people cannot really use troponin in recurrent MI. Troponin has to be ordered in acute setup, right? You people have to order CKMB in case of recurrent MI because it normalizes after 24 to 48 hours.